In this video, we discuss the evidence suggesting that blood filtration can improve cancer outcomes. As always, these ideas are discussed in more depth in the book Cancer Self-Defense 101. Quick tips to help you survive. All citations for studies quoted in this video can be found in the book's bibliography at cancerselfdefense101.com. This video is intended as information, not medical advice. It is not intended to treat, diagnose, or cure any disease. Any medical advice should come from an appropriately credentialed medical professional familiar with your unique circumstances. Tumor necrosis factor alpha, TNF-alpha, is an inflammatory molecule produced by immune cells that has shown the ability to destroy cancer in humans. If macrophages, a type of white blood cell, detect an infection or threat, they release TNF-alpha to alert other immune cells to initiate a response. Cancer protects itself from TNF-alpha by overproducing its receptors. The cancer membrane produces so many of these receptors that they cleave off and flood the microenvironment surrounding the tumor. TNF-alpha interacts with these cleaved-off receptors, called soluble tumor necrosis factor receptors, STNFRs, thereby blunting the immune response and allowing cancer to survive. There have been attempts to remove these STNFRs from circulation for decades. Before STNFRs had even been identified, there had been research into therapeutic blood and plasma transfusions, called plasmapheresis, in an attempt to remove immune-blocking factors from the blood. In 1908, Dr. George Cyril, co-founder of the Cleveland Clinic, and Dr. S.P. Beebe, a Cornell University professor, demonstrated that blood transfusions had a therapeutic effect in dogs with cancer, even completely eradicating disease in several cases. Other animal trials showed similar effects. It seemed as if these early experiments were lost to history until the effects of blood and plasma transfusions on cancer in humans were re-examined in the 1970s. A 1977 article published in the prestigious journal Cancer examined the effect of therapeutic plasma transfusion to remove the A's of then unknown immune-blocking factors in cancer patients' blood. Surprisingly to the authors, 8 of the 23 advanced cancer patients showed a partial response, documented 2 to 3 weeks after the first plasma transfusion. A follow-up trial by the same authors found plasma exchange, 4 to 5 liters, conducted every 48 hours, was superior to transfusions every 72 to 96 hours, as was the case with the 1977 study. Similar benefit would be found across a wide variety of cancers, including head and neck, oral, colon, melanoma, and more. Plasmapheresis was found to be particularly beneficial in multiple myeloma. In one clinical trial of 25 people with multiple myeloma, plasmapheresis produced improvements in 44% of patients, with blood markers of disease being reduced anywhere from 30 to 80%. Another trial showed plasmapheresis dramatically reduced rates of kidney failure in multiple myeloma. It was soon discovered that plasmapheresis improved immune parameters in the blood, including natural killer cell activity. It was speculated that the disappearance of immune-blocking factors led to the improvement. By the early 80s, plasmapheresis was being combined with other treatments in an attempt to find synergies. In 1981, 32 patients with chemotherapy-resistant tumors were retreated with the previously ineffective chemotherapy after plasmapheresis. 19 of 32 patients showed a minor response or no change lasting more than 3.5 weeks. In 10 of the 32 patients, the effect lasted for more than 8 weeks. A few years later, another trial examined large-volume plasma exchange in 69 cancer patients refractory to chemotherapy. When plasma exchange was combined with chemotherapy, 54% patients had a response. Plasmapheresis was also found to improve the outcome of radiation in 22 pancreatic cancer patients. It also decreased mortality after surgery in lung cancer patients. In 2020, plasmapheresis was examined in conjunction with anti-PD-1 immunotherapy in melanoma patients and found to confer a significant benefit. Plasmapheresis has also showed efficacy against paraneoplastic neurological disorder, a rare yet devastating immune reaction in which cancer patients' immune system damages, sometimes fatally, their own central nervous system. Plasmapheresis has also been shown to have a positive impact on a myriad of other conditions aside from cancer, including Alzheimer's disease. As scientists examined the effects of plasmapheresis on cancer, they discovered that filtering out molecules above or below a certain weight had differing effects on disease progression. Animal trials revealed that plasma from cancer patients, which included higher molecular weight compounds, greatly stimulated cancer progression, while plasma that had the higher weight compounds filtered out reduced the rate of progression. This effect was even more pronounced when combined with chemotherapy. In the early 1990s, the primary immune-blocking factor, STNFRs, was discovered. The negative impact that STNFRs had on patient survival was confirmed shortly thereafter. A pioneer in the field of optimizing plasmapheresis for its maximum anti-cancer benefit is Dr. Rigdon Lentz, head of the International Immunology Foundation. The name for Dr. Lentz's technique has gone by different names over the years, including immunoadsorption, oncopheresis, and immunopheresis. Dr. Lentz began his first phase 1 clinical trial in 1985 with an early version of the plasma filtration technology based on molecular weights. The study enrolled 16 people with late-stage metastatic cancer. With 3 exceptions, there was a general improvement in condition. 6 of the 16 patients had a reduction of tumor burden of 50% or more, a far superior result compared to what would have been expected with standard of care. The 3 exceptions mentioned above were actually the first 3 patients ever treated, who died from tumor lysis syndrome, a fatal complication of a tumor dying and releasing its contents too quickly. Notably, upon autopsy, all 3 of these patients demonstrated that, quote, all measurable disease, end quote, had been eradicated from their bodies. In 1986, a phase 2 trial in 72 patients with various stage 4 cancers who had exhausted other options demonstrated a similar level of benefit as the first trial. No tumor type was found to be particularly more or less sensitive than another type. When STNFRs were discovered in the early 90s, Dr. Lentz updated his technology to filter and sequester them. In 2001, Dr. Lentz was conducting a human trial with the updated filtration device, when administrative errors in record keeping led to sanctions from the FDA. This tarnished the public perception of his technology. Subsequently, he moved his operations to Germany. In 2006, Dr. Lentz conducted a human trial in Germany for a new iteration of his device called the OncoSorb. OncoSorb was first used in a trial of 9 people with stage IV cancer. The trial demonstrated dramatic decreases in STNFR1 and STNFR2 and reductions of tumor size in the majority of patients. This chart demonstrates that the OncoSorb device brings down the blood levels of SR1, SR1, SIL2R, all used by cancer to evade immune detection. The dark and light green are pre- and post-treatment in cancer patients, while the red and beige are the high and low range for people without cancer. A patient in the 2006 trial with head and neck cancer demonstrating a visibly shrunken tumor after treatment. Another study of 15 breast cancer patients with metastatic disease showed that OncoSorb led to tumor size reductions of 50 to 75%, with all patients having improved quality of life. The success of these trials led to the approval of OncoSorb in the European Union with a CE mark. The CE mark confers regulatory approval throughout the entire EU, as well as other countries that acknowledge the CE mark. The US and Japan are notable exceptions. The CE mark approval allows Lentz to offer his services to paying clients out of his clinic in Germany. Dr. Lentz summarizes the clinical outcomes of the treatments from his private clinic on his website. The overall response rate, ORR, is 75.4%. Average N per cancer type equals 6.9. Overall responses consist exclusively of complete responses, CR, that is remission, and partial responses, PR, meaning a decrease of tumor diameters of 50% or more, which is clinically very significant. Of the above overall responses, 42.3% were CRs and 57.7% were PRs. For the top 5 cancer types that respond best to oncopheresis, the ORR is 100%. Considering all 102 evaluable patients treated by oncopheresis, representing 25-plus solid tumor cancer types, overall responses have been documented in 61 cases, 60%. Another company conducting human trials in immunopheresis with positive results, this time in America, is Immunicom. The LW02 is the heart of the Immunicom immunopheresis device. In 2018, Immunicom tested its STNFR filtration technology in dogs with mostly refractory stage 3 and 4 cancer. They achieved a disease control rate, either stable disease or partial response, of 50 to 60%, resulting in significant life extension. In over 300 treatments, no adverse events were attributable to STNFR filtration. In 2021, Immunicom published the results of a human clinical trial in 7-stage IV triple-negative breast cancer patients who were already refractory to an average of 3 lines of chemotherapy. Their technology produced a response rate of 29%, including 1 complete response. In the 5 patients who completed at least 4 weeks of treatment with STNFR filtration, the response rate was 40%. The success of this trial led to the FDA granting Immunicom a breakthrough device designation for stage 4 metastatic cancers and a CE mark for advanced refractory triple-negative breast cancer in the EU. In another Immunicom trial conducted in refractory stage IV melanoma and triple-negative breast cancer patients, STNFR concurrent with an immune checkpoint inhibitor, Opdivo, produced signs of immunological benefit. As of early 2022, this trial is still ongoing and shows promising signs. Currently, treatment with an Immunicom device is only available in the US through clinical trials. Importantly, there are very few adverse events associated with STNFR filtration, as it is a subtractive process, removing something from the body, rather than an additive process, such as chemotherapy, etc. Perhaps the most dangerous side effect of STNFR filtration is inflammation at the site of the tumor, which can make treatment of brain tumors particularly challenging. Although research into blood plasma filtration is gaining ground, could it be even more vigorous? The levels of SETNFR in people without cancer are lower than people with cancer. Why not filter plasma from people without cancer, then administer it to people with cancer? Additionally, STNFR is not the only immune-suppressing compound in the blood. Cancer sheds PD-L1 receptors the same way as it sheds TNF-alpha receptors. These shed PD-L1 receptors interfere with the efficacy of anti-PD-1 drugs, such as Keytruda and Opdivo. This is why plasmapheresis was found to increase the efficacy of anti-PD-1 drugs in the trial mentioned earlier. One study has explored the effect of donor qualities on outcome. In 2008, scientists screened donor blood for its ability to kill a neuroblastoma cell line. 9 children with relapsed neuroblastoma received a complete exchange with the donor plasma. In 3 patients, minor tumor responses were observed. In 1 patient, stable disease was maintained for 3 years. In another child, who received 10 therapy cycles, disease-free survival was maintained for 8 years without any further therapy. This was confirmed in another clinical trial. This first revolutionary paper mentioned has been cited in other scientific articles all of 3 times. There is a distinct possibility that limitations on profitability may be a hindering factor into anti-cancer research on donor plasma. For more information, please see the book Cancer Self-Defense 101: Quick Tips to Help You Survive.